So just a few notes. This webinar, as well as the technical issues, are being information that's being presented today is designed for health professionals. So it's going to take a bit of a deeper dive into perinatal psychiatric management from a medical perspective. Please do type in your questions and any comments that you've got. We'll try our best to answer them. Take photos of slides. There are going to be some of the contents of today's webinar made available in due time. It will need some editing, obviously, and we'll also be sending out the slides themselves. So we're actually presenting tonight's webinar in conjunction with our partners, the Gidget Foundation, and just of a vibrant young lady who lived in the northern beaches of Sydney, who quite tragically took her life while suffering from postnatal depression. She didn't tell anybody about her depression, and people didn't know that she was suffering, including the people closest to her. After the passing of Gidget, they got together and created what's now the Gidget Foundation, determined to make sure that no one else goes through Gidget's fate. So that's just for women suffering from perinatal mental health issues. The Hand That Rocks the Cradle, I ummed and ahed about whether to include the poem, but then I came to the conclusion that I really should, because it really highlights why we're here today. Blessings on the hand of women, angel guard its strength and grace. In the palace, cottage, hovel, oh, no matter where the place, would that never storms assailed her, rainbows ever gently curled. For the hand that from a poem by William Ross Wallace, 1819 to 1881. So it's done its years and still remains relevant, of course, and I think will remain relevant forever. So we're here with the best evidence-based advice regarding psychiatric treatment of perinatal mental health populations. And increase as well your confidence and resources that are available to you to do just that, to provide the best treatment that you can to your patients. And well-being of mother and baby are inseparable, intertwined, whether from a biological, psychological, social developmental perspective. One depends on the other, and almost vice versa, really. So when you caring for to look after herself whilst keeping her child, her unborn baby in mind, recognize the vulnerability and the value of the dyad, and bearing witness to her story in whatever way it kind of comes, and in the way that she's experiencing it. It's not just a time of physical change, it's really a time of huge biological, chemical, neurological, it's all driven by that you see on the graph in front of you, actually, with 10 to 15 fold increases in progesterone and more than a lifetime worth surge in estrogen. That's got to impact the rest of the system, right? And in terms of is shifted in some way, it influences the others as well. And this is no different. So, and in parallel, there's changes also in the neurobiology and the neurochemistry of the woman. We've got lots of animal studies that show us that there are changes in gene expression, cell proliferation rates, a lot of functional alterations, but also morphological alterations. As the body and the mind go through an adaptive process with long-standing changes, and we've actually found that certain regions of the human brain in first-time mothers are grossly changed in comparison to nulliparous women. And some of these changes will last a lifetime. Functional MRI scans have actually shown some quite ubiquitous and synchronous changes in the neurobiology of women during pregnancy. Lights out, not quite, but lights dimmed maybe in the medial regions of the brain. So there's the whole medial region is responsible for the interoceptive function. So the looking in, the identifying what's happening with me. And the parts of the brain, the anterior cingulate and the more lateral function really light up. And these are the parts responsible for social cognition and for interpretation of other. Mindful of that baby and tuning into their cues. So, in summary, neuroanatomical changes are specific and they're evidence of drastic change in social cognition that allow the mother to adapt to the impending motherhood and gearing towards that very important infant bonding that then drives the attachment process. And just as a side note, if you're interested in child development and attachment, visit webinar. I'm sure many of you have seen it in your medical textbooks, just a chart of the developing embryo and then fetus. And the takeaway message from here is the purple shaded bars are where the organogenesis happens, so structural formation of the major organs. The central nervous system does extend as you can see, most of the organogenesis is complete within the first trimester. A lot of it is well and done. Time is taken not in the actual organogenesis, but in the further development, proliferation, and shaping, as well as functional development of the body of the baby. And we have to be mindful of that when we're starting medications. When is it that medications are likely to have an impact? And we'll get to that a bit later in the webinar. Important to highlight, and as I keep on being reminded over and over again, you don't need to have a medication on board to have an issue with a pregnancy or a complication. Spontaneous abortion in the first trimester of pregnancies that we know of, example, spontaneous malformations without a genetic loading, without a family history, and certainly without medications, happens in 1 in 40 live births. And all sorts of environmental factors also add to the related to increased incidence of neural tube defects. Now, psychiatric illness during pregnancy is actually an independent risk factor itself for all sorts of issues with the newborn, including endocrine axis shifts, congenital malformation, fetal distress, preterm delivery, preterm rupture of membranes, all those sorts of things are independently sorry, there is part of my screen that's being covered. How do I get rid of that? Is everybody able to see okay? Yeah?
Yes,
Okay.
Katrina, we can see.
Okay.
Yes, Lara.
No
What do you
worries.
have on your screen? What's blocking it?
No, there's a bar that's come up on the top here, that's all. But we can ignore that, that's fine.
We can see it clearly.
Okay. Okay, great. So when it comes to perinatal psychiatric conditions, there's an entire spectrum. And it's a spectrum in terms of individual conditions, as well as a spectrum of of what could possibly happen in that perinatal period to hopefully prevent, if not apply early intervention strategies. And this has got to do with the screening and early identification, and then, if required, treatment, and then taking a recovery approach to assist the mother and disorders range from the more common mood disorders, anxiety spectrum disorders, and certain personality disorders that can become more activated in the perinatal period, to issues such as substance use during pregnancy, eating disorders that can flare in the perinatal, postnatal period, and psychotic spectrum disorders that happen a lot more rarely, but certainly out there. Across the severity of illness, medications are a component of a comprehensive biopsychosocial paramount when looking after mothers and their babies in that vulnerable time. Now, adjusting to parenting versus adjustment disorder, two very different things. Adjusting to parenting, well, it's a major milestone. Let's just say it's monumental and life-changing. They would be a little bit anxious, worried, scared, maybe even overwhelmed by the prospect of becoming a parent for the very first time. And this is normal. So it's an Ericksonian milestone that generativity versus stagnation stage is finally being embarked on, and you're going to be a bit overwhelmed and stressed. Adjustment disorder is a different condition altogether, and it's a DSM diagnosis. So basically, the presence of emotional behavioral symptoms in response to an identifiable stressor or stressors, which occur within 3 months of the beginning of the stressor. Now, I do have the DSM criteria right here, and I'm not going to go through them, but the thing that I really must point out is that the distress needs to be out of proportion for the stressor, and it needs to be clinically significant. So that is adversely impacting function and impacting in terms of clinical levels of distress. And it could be due to a kind of a catastrophic event in a person's life, or it could be something very simple like a developmental milestone, like getting married, moving out, becoming a parent. I guess moving on from that, it'd be important to highlight that baby blues, which is a self-limiting ubiquitous condition or experience, I should say, rather than condition, because, you know, pretty much 80% or more of women experience postnatal blues, versus benign, totally benign, versus postpartum depression, which is more of a concern. And, you know, keys to what you might be dealing with kind of come in the onset of baby blues tends to be, you know, day 2, day 3, lasts for a few days, maybe a little bit longer, but self-limiting and quite mild. Whereas postpartum depression, you really need to have the symptoms there for at least 2 weeks. It tends to have more severe symptoms, and there can be a rapid spiraling and can occur quite a fair bit later following the delivery. It could be months following delivery. Perinatal depression is more likely if there's been a previous peripartum depression, but it can happen whether there's been a previous episode or not. The risk is cumulative, so with successive pregnancies, the risks are higher. Also, multiple pregnancies, so twin pregnancies, are higher risk still, with more significant shifts in gonadotropins. The severity of the manifestations do differ, so you can have more milder end spectrum presentations versus more severe end spectrum presentations. But I think overall we need to acknowledge that it does present a significant risk both to the mother and the baby, and to future outcomes for the baby as well. So being able to be responsive as a parent, responsive parenting, infant development, which depends on that attachment relationship between infant and the primary caregiver, are really, really quite important. And that's in addition to all the other risks that I've discussed earlier in a previous slide. So Dsm criteria, again, I'm not going to go through the Dsm criteria one by one. It's in the Dsm. So the thing that I will highlight is the minimum 2-week duration. You need 5 out of 9 symptoms to be able to diagnose it. And it's diagnosed under the umbrella of major depressive disorder with peripartum onset. So that's the specifier down here, the peripartum onset. And the symptoms need to cause significant impairment. So that's how it's diagnosed. Now, a note about screening. So there are a number of screening tools that I have there on the screen. And we need to be mindful of the sort of principles that we abide by when we're administering screening tools. So most of you will be quite familiar with the Edinburgh Postnatal Depression Scale. And maybe even the antenatal risk questionnaire, which is more of a psychosocial risk questionnaire. The EPDS is, you know, screening for depressive disorders and anxiety disorders. And I have to say that clinical judgment is paramount here, because these are only screening tools. They're not diagnostic tools. So when we get an arbitrary cutoff score of 13 or over on the EPDS, it doesn't mean that we need to jump in and treat or refer to tertiary referral services. It means that we need to be mindful that this patient may be at risk, and that we need to continue to monitor and further investigate. So when we get a positive score, we go in a bit deeper, and we try and find out what's going on for that individual. And we might take up sort of additional precautions, repeat the EPDS, you know, administer a HAM-D, Hamilton Depression Scale, administer a HAM-A, Hamilton Anxiety Scale, etc., and get them seen by specialist mental health, CNC, or get them referred on further to the Safe Site Clinic, which runs in a number of different sites now in the public system. That sort of thing, it can be very helpful. Now you'll find more information on the key rating scales, particularly the screening scales, on the COPE website. So that's the Centre of Perinatal Excellence. And also one more thing to keep in mind, be trauma sensitive and expect that because of the ubiquitous nature of complex trauma, that your patient is very likely to have had to deal with difficult situations. It could have been early in childhood, and this is a period of time when that sort of thing will surface. Also, be culturally sensitive. A questionnaire may come back with unbearably low scores, and that may be because your patient simply doesn't understand the wording, but it doesn't necessarily have to do with language. If we consider our Indigenous population, our refugee population, a lot of the time they're quite suspicious of some state services, also quite worried sometimes that if they're diagnosed with depression or anxiety or whatever it may be, that child protection will be suddenly called into the picture, and that they're at risk of losing their child. So just be very mindful that our population of interest is a very diverse and has quite disparate needs. So why is it so important to treat? I think I've been harping on about this quite a fair bit already, but I just can't stress enough that the negative ramifications of not treating are just so crucial to consider. Just impact on the woman's capacity to participate in her birth planning or attend her antenatal clinics, or even be able to parent. These are all affected by her mental state. If we don't treat, the woman will try to treat. She will try to cope in one way or another, whether it's self-treating with substances, whether it's overeating, whether it's self-harming. Something's going to give. The other thing I want to talk about is high fetal cortisol exposure. So the thing behind that is when mum is stressed, when there is that psychological, psychiatric stress, it's going to result in HPA axis deviation. Her cortisol levels are going to go up, and if she's not sleeping properly, she's going to have pervasive and persistent raised cortisol. Can you imagine what effect that would have on the fetus? Now, studies, I won't let you imagine, I'll tell you that the studies have actually shown that hippocampal development is affected majorly. I don't have the figures here in front of me, but if you want them, I will mail them out to you. But there are major impacts on the volume of the hippocampus, for example, major impacts on connectivity in the limbic system and those parts of the limbic system that are responsible for emotion regulation. So it really can have long-term adverse consequences on child development, behavior, social adaptation, and social function. So it's really quite important, not to mention that the cognitive development of a child is predicated upon the emotional development of the child. So again, go to webinar 3. I'll stop there. Otherwise, I'll talk about it for another 2 hours. So when it comes to looking at risk factors for perinatal mental illness, there's a whole gamut of risk factors. It's not just the biological loading for mood disorders or psychotic disorders. It's not just socioeconomics or demographics. Things like birth trauma. And birth trauma doesn't have to be a massive bleed in the middle of the delivery. It could be feeling disempowered and helpless during the delivery. It could be personality and coping mechanisms, or substance use, or having something go wrong with the baby. Even if it's not a major issue, but for it's the mother's experience that really counts, and not our interpretation of it. On that note, you may have guessed that I am quite interested in the topic of trauma. And it becomes really quite pertinent at this point, because a lot of times mothers' own experiences of being taken care of. Now, the of their parenting blueprint, the internalized blueprint, that becomes quite pertinent at this time. And developmental trauma starts rising to the surface when it's time for them to have their own baby and embark on parenting themselves. Because information is sought in a very use-dependent fashion, the ramifications on the neurobiology of the fetus and the newborn is so important. Hence why, early intervention, this is true early intervention if we really consider it. Again, maternal state of arousal is going to have a significant impact. So different neural systems are being activated at that point. And in addition, the normal development of the child is trying to take place. And in this process, there are the critical periods where they need to have exposure to certain environmental cues and stimuli in order for them to be able to develop in a healthy way. Now, what if that system was overrun by stress? And what if that didn't allow for those critical periods to have the appropriate exposures? Now, this is more on brain development. I won't go through the whole slide. That's why I said see webinar 3. But again, emotion and not cognition drives the development of the fetal brain. So this is all kind of funneling down to why it's so important to have cooperation and collaboration at this point in time. And nothing summarizes it better than the first 2000 days framework. The whole concept behind that is intervention at conception until the age of 5 can tremendously direct and redirect the trajectory of a child's development. And rather than a child who grows up having significant issues with conduct and behavior and emotional well-being, we can really shape them up to have a much more successful and peaceful development and progress throughout their life. So this is just a post from the first 2000 days initiative. And look, I've just put this up just to kind of highlight the continuum. So, we're looking at adolescence. This is actually a full circle. Adolescents, a lot of us come into contact with adolescents having tremendous difficulties adapting. And when you go through the steps, you actually see that early intervention with mum and baby and the mother-baby dyad can kind of really alter the outcomes. And always remembering that the mother, baby, the child is in the middle of concentric systems, and those concentric systems are very important to consider, because collaboration And what we know very well in primary health, the vertical integration of the systems is so important. Again, the close cooperation may extend across boundaries, not just different disciplines, but different agencies altogether. And the better the cooperation, the better the outcomes, and exponentially better. So I've included this slide on engagement and follow-up because in our previous webinars, some of our attendees asked the question, well, how would you engage someone, a woman who's so reluctant? Now, actually, what studies have shown is that over 97% of women want to be asked. They want to be asked about their mental health, and they want to be asked about their psychosocial situation, and they want to be able to access support. If you don't ask, a lot of women won't just offer it. And the interesting thing is 30% of Aussie women or women in Australia opt for private, private obstetric care. And that's fair enough. They get a beautiful, beautiful room, and they get their obstetrician and all the rest of it. But they really do miss out. They miss out on the screening. So they're really disenfranchised from that opportunity to have the initial screening. And what's beautiful at the moment is that we've managed to incorporate the first 2,000 days into our public networks. So certainly, utilize it as much as possible and be curious. The Therapeutic Alliance, particularly with the GPs and the midwives and the front line, in such a unique position to be able to cultivate that therapeutic alliance and get the trust. So be curious and be reflective in listening to the woman's story. Be proactive, book the next appointment. And in GP land, so when I used to be a GP, we always spoke about the opportunistic interventions, the brief interventions, which are very popular in drug and alcohol world as well. And they certainly apply in this period. It's also very, very useful if somebody has a partner who's struggling. This is a good time to be able to capture that, because dads suffer too. Remember, it could be their first time being a dad as well. There could be other things in the background. So they're also at risk. The role of motivational interviewing, definitely. What are the good things about having a mental health condition that's untreated? What are the less good things about having a mental health condition that's untreated? And now I'm just being facetious, but you get the idea. That could be a way to also help them along that, change spiral, that Francesca Di Clemente cycle of change. And you don't need to fix anything there and then, just remember that. It's planting seeds. So we're going to finally take a pause and take a look at some of the contents of the Chatana panel, wonderful panel. We'll get an opportunity to answer some of these. I'll hand back over to you, Katrina.
Hopefully I don't break up a lot this time. My thing's coming up saying internet connection unstable again, of course. And I just want to welcome Dr. James Brown. He has joined us during the presentation, so glad you can make it, James. Dr. Uncle, is there anything that you want to speak to?
Yeah, thank you, Katrina. First of all, thank you so much, Dr. Havari, for such a great presentation. Very thorough and very, very pertinent to the subject. When I can't emphasize the fact that the working in the perinatal field is probably one of the finest example of primordial prevention, as in you're not even preventing, you're not just not preventing the disease, you are even preventing the risk factors from happening for the child, the future child, to have mental illnesses in the future. So this is a field where probably very focused intervention can reap a lot of enormous good. So it is such an important topic to focus on, and that's why Dara, you actually touched upon really very, very important issues about the depression, the fact that depression is so easily missed, and many women do not even come asking for help, even though, as you mentioned, almost 97% of women would like to be asked about their mood. And similarly, in the chat, you mentioned, Katrina, that 50% of the partners of women who have postnatal depression also have depression or some kind of struggle with mental health problems, which we often miss. In fact, a very recent conference by the Marseille Society actually focused on the fathers. So a lot of times we focus only on the mothers and not the fathers, but we should be focusing on the family as a whole rather than just the mother. So yeah, thank you so much for your presentation.
Thanks, Uncle. Dr. James, I'm going to throw the next one to you about women not being screened by their obstetrician.
Yeah, sure. The answer to that is that they are, but not as structured as perhaps what is in the public system. So the majority of private consultants probably would do an antidepressant scale. They don't have as much of the other formalized screening processes, but overall, they all do get an antidepressant scale filled in, but perhaps it's not sort of as structured and as formalized as you'd expect sort of in the public system. And perhaps that's somewhat offset by the fact that they've got a longitudinal relationship and they technically have someone they can call any time. So perhaps informal screening happens over time to supplement that, but it's not completely deficient, but it's not as good as the public system due to the kind of consistency.
Yeah, there's definitely there is discrepancies there. It's not always ideal, but you're right. Like that therapeutic relationship perhaps is underpinning there as well. So yeah, if you connect with your healthcare professional. So thank you. Hey Laura, we got lots to get through, and because of my internet issues at the beginning, we're a bit behind.
We are a bit behind, but no worries. Let's carry on. We might go a little bit over because of the initial struggle. So anybody who misses out on the last little bit, if you can't stay, that's fine. The recording will be made available. Is it still on the Gidget site or not for this one, Katrina?
Not there yet, but once it's had a little bit of editing, Gidget will put it onto their YouTube site. So
okay.
And then I'll share it out with the emails from people who have registered. So
Great.
That's the plan.
Thank you. So yeah, it will be available, and yeah, you'll have access to the slides as well. So yeah, diagnosing, screening, working through, it's a conundrum. So the risk-benefit balance is quite complex. There are a lot of factors here to consider. Yes, there are some risks in the use of psychotropic medications, but there are potentially much worse risks of not treating. And some antidepressants have, oh, I said antidepressants here on this slide, but you know, what psychotropics, period. Some of them have a great track record. Okay, so we need to be able to use what we've got in the best way possible. And I'll talk to that a bit more later. Now, you know, most of you are also familiar with the TGA classification of drugs in relation to pregnancy, lactation, and whenever we, you know, refer back to MIMS, we see it. It's there. And the only thing that I'm going to highlight here is we're not going to have that many psychotropics up in category A, because you know, when we do go for a research proposal, when we put that through ethics, we're not likely to get ethics approval to experiment on pregnant women. So they're not really part of the cohort of inclusion criteria for any of the studies that we rely on. So really we're relying on ad hoc information, case reports, and whatever else is out there, animal studies. So we're going to get category B, C, and D. And to be quite honest, category B does not imply or should not imply safer than category C. That just means we've got a little bit more information on the category B as opposed to the category C. So that's the first point I'd like to make. Secondly, again, when I was a GP, this always struck me because I'd have women who'd come in and see me and, you know, say, am I allowed to have the nicotine patch? Because I don't want to smoke during the pregnancy. And I'd be like, of course. And they'd say, oh, but it's category D. Isn't that better than category X, smoking? So we've got to exercise clinical judgment. It just, we can't get by without it. And if the risks that we're avoiding are higher than the risks of the medication that we're using, then we really need to kind of think about it and give it a go. So this is just a bit of structure to the slides that are to come. Basically going through step by step the things to consider when prescribing psychotropic medications. And I'll start with principles because we like to do that in medicine. Define your target symptoms. There's no point starting a medication unless you know what it is you want to manage or make better. If it's a low mood, use a medication that targets that. If it's anxiety or if it's a sleep disturbance, use something that targets that, not something that's going to just cast a net out and, you know, yeah, broad spectrum, no. Choose medications that we have some information on and seek support, seek guidance. There's nothing worse than avoiding everything when you've got resources there that can be tapped into. And I've got Mother Safe on a slide, you know, great resource for medications during pregnancy. Muse monotherapy over polypharmacy. If you use the lowest effective dose, and that is the lowest effective dose. If you need to go higher for it to be effective, then you go higher for it to be effective. And that's better than polypharmacy. Then you're avoiding drug-to-drug interactions. When you're starting, start low and go slow. Because not only are you working with altered physiology, but you're also kind of depriving yourself and your patient of the opportunity to see if a lower dose is enough. And we've got clinical practice guidelines. Go for them, but just remember they're only guidelines. And please never discontinue pre-existing medication abruptly because you discover that your patient is pregnant, even if it's sodium valproate, which is highly teratogenic, but still do not discontinue it because you found out a patient is pregnant, because the ramifications could be quite catastrophic, a lot worse than the medication itself. Think, consult, and discuss the pros and cons of each intervention that you're suggesting with your patient. Remember, she's a competent adult with decision-making capacity. She's making a decision for herself based on expert advice and adequate information that you provide. All right. So this slide is basically a summary of the strategy of prescribing. So if you'd like to take a moment and just take a screenshot of this, go ahead. But if you don't, that's fine. It will be available in the slides. And I've found that it provides a really nice summary, just a reminder. Okay, non-pharmacological interventions, of course, go for those at the first instance. That's part of the, the hierarchy of the process. We've got some gold standard interventions, CBT, cognitive behavioral therapy, IPT, interpersonal therapy. But there are a whole gamut of other interventions that are also available and also very effective depending on the needs of your individual patient. In terms of IPT, I mean, it's really often quite indicated for changing roles when there's and interpersonal effectiveness or function is being threatened or being altered. And of course, what greater change of role is there from a change of, a highly organized barrister becoming a very disorganized and overwhelmed new very is very, very important at the outset, especially that, this woman is going to be quite sleep deprived very soon. So that's in the antenatal period, of course. But even in the perinatal period, being able to sync the sleep cycle with bub is something very delirious women post delivery, presenting as psychotic. They're just delirious. They haven't had any sleep. They may have lost a pint of blood, and they may be on very strong painkillers because they've just had a cesarean section. And once all that is rectified, they're well. I can't tell you how many women I've seen who fall into that category. They may have even been prescribed an antipsychotic that I then deprescribe. I'm sure you have as well, Dr. Uncle, yeah? And I've seen somewhere in the chat that previous experience can have a phenomenal effect on acceptability of future interventions. So make sure that these things are addressed. The big elephants, they need to be addressed. And what else is happening? Remember, psychosocial issues have a huge impact, and no medication is going to treat the domestic violence that's happening in the background. Yeah. Personality disorders fall into that same category. If your woman needs some DBT skills to cope with quite dysregulated mood states, that's going to do nothing. All right. Diagnostic reasoning, very important here. Again, if you have a melancholic depression, no amount of CBT is going to cure it. So just being mindful when diagnosing and really looking at the keys that suggest that a pharmacological intervention will be anyway, but just be conscious that these things are happening in the background. Drug and alcohol misuse is a very common one. So quite significant mental health issues, and with a dual diagnosis of drug and alcohol, they may be on substitution medications as well. We really need to have collaboration from drug and alcohol or substance GP and all the whole gamut, So just a note on risk-benefit analysis, fill in a matrix. What are the benefits and what are the risks? And that will usually help you as well in counselling your patient that involve other family members or partner, or it's all right. Once you get a matrix, a risk matrix together, you're influencing 2 lives. There aren't that many trials out there, and we're relying on ad hoc data. The guidelines are vague and consensus-based at best, and there can be quite significant medico-legal implications. That's where collaboration comes in quite handy. There's multiple professionals and teams who can then be provide guidance for one another and guide the patient as well. So the last bit I'll try and go through quite quickly. My focus will be on the antidepressants because they will be used most of all in the primary care setting. And look, to be quite honest, we've got SSRIs now. They are relatively safe drugs. There's low birth weight, respiratory conditions, primary pulmonary hypertension in the newborn is another one that people worry about. But to be quite honest, if you're not prescribing paroxetine, you're generally okay. So paroxetine is the one that's been most associated with cardiac malformations when used in the first trimester, in the initial 4 to 6 weeks, and then when used persistent pulmonary hypertension of the newborn. And then, of course, because it's got such a teeny tiny half-life, the discontinuation syndrome in the newborn can be quite distressing. Now, late exposure to other antidepressants syndrome are there, and with the discontinuation, the most common things, and I think Dr. Brown, you can tell us more about that, but the most common sort of presentations are fussy but difficult to settle. And I'm not sure if you want to add anything more. That's a great summary. Thank you. Some may need care in the special care nursery or NICU. That kind of depends, and sometimes has a lot more to do with prematurity rather than just the exposure to SSRIs. But there's collaboration for you. The involvement of a neonate. Now, other antidepressants that might be used, of course, if you have a melancholic depression, SSRI might not be effective. And you'll probably need to refer on to a perinatal psychiatrist anyway. But tricyclics are actually quite safe as well. They do come with some risks, particularly cholinergic rebound. Things, and it can come with a discontinuation syndrome, much the same as SSRIs. But you know what? Secondary opposed to amitriptyline, it might be, just right. And usually we don't find that there are many complications at all. And discontinuation syndrome is usually quite mild and self-limiting, but again, can sometimes be a bit distressing. Now, I am speaking briefly about sodium valproate and lithium. just because of the anxiety that they create. And they don't create anxiety for no good reason. So sodium valproate is quite teratogenic. It's quite high risk, 7.2 significant. And other malformations as well, particularly quite distressing for the parents with the facial and skull malformation or heart defects. But if you stop the medication quick, smart, it can have more catastrophic effects. And the funny thing is that a lot of disorder, for example, won't actually work out that they're pregnant that early on. You might come into contact with them 9 weeks into the pregnancy, 12 weeks into the pregnancy, and by then discontinuing sodium valproate isn't going to anymore. It can be managed, it needs to be managed, and most of the time, the patients started on sodium valproate by their psychiatrist are going to get their due information about how teratogenic it is and the importance of contraception, and it's going to be repeatals. ASD, autism spectrum disorders, have also been associated with sodium valproate. So you know, it is a big deal, but just refer, please. Now, an example where pregnancy not okay medication is lactation in pregnancy, very safe in breastfeeding, 90% protein bound. So women can be on it and breastfeed, but as Dr. Srivastava once told me, why would you start them on sodium valproate again if they're going to have another baby? So just be mindful of that. Again, I will highlight on every slide that collaboration you can't go without. Lithium, again, used in bipolar affective disorder, particularly good anti-manic drug. Risk of fetal toxicity, of course. Or the early first trimester exposure. If a mum's on it, again, I've seen this before, presents, you know, at 12 weeks and you find out she's pregnant, please don't discontinue it. The risk of having a baby with an Epstein anomaly risk. And a lot of the risk can be mitigated with very, very careful monitoring, minimizing the dose. But of course, this needs to be done under specialist care. Now, discontinuation of lithium, whether its pregnancy carries an enormous risk of relapse postpartum. So these patients absolutely need to be referred on to a perinatal psychiatrist. And just be mindful that even though lithium is not so safe in the first trimester, it doesn't make it doses need significant adjusting, both in the third trimester and immediately after birth. So this slide is just some, you know, useful recommendations, some happy drugs that we find are particularly, have a particularly safe profile. So again, if you want to take a photo of that. Breastfeeding. And the motivation behind this is also to highlight that not all your patients are going to want to breastfeed. Just babies, not all babies. Again, be curious and mindful why a mum might choose not to breastfeed. Has it really got anything to do with the medication? Some mums have had horrible experiences, either with a or a previous, post-delivery experience, or has actually her own history of sexual assault. And maybe breastfeeding is just too viscerally unsafe. You can't have a dysregulated mother breastfeeding. That's not safe for the baby. It's actually so much safer to just feed formula. But say you've got a mother who wants to breastfeed, feels viscerally very, very safe to do so, and has problems with lactation. Again, one needs to be mindful. Before prescribing Motilium, please think, how is this going to affect the mum's mental state, hypothalamic pituitary axis? You're going to get anxiety symptoms, mood symptoms, and possibly other symptoms as well. So just be mindful, and be mindful of your interactions. They need to be trauma informed and sensitive. So the things that I've heard from women about why their baby's not feeding from various clinicians that they've come into has been astounding, particularly the one and it can cause a lot of unnecessary distress. Seek advice and consultation, particularly lactation consultants, midwives, child and family health nurses. They are very, very well placed to provide enormous amount if you are starting medications. So I use prazosin quite a fair bit in my practice, and I will always advise, express before you take your dose. Don't breastfeed straight after your dose. Give it a couple of hours, and maybe your partner can help with the night feed so you can get some sleep. So the lactation consultants are all over it. So are the child and family nurses. So this is the Mother Safe slide I was telling you about. Sydney grown, wonderful resource when it comes to medication safety. Make the call with your patients. Because COVID-19 is so topical at the moment, I just thought we'd include a couple of slides on that. But really, bottom line is it can be passed vertically from mum to baby. Yeah, it happens not very often, but it can. Anxiety about having the COVID vaccine because they might be becoming fertile, or it might have a bad effect on the pregnancy or the baby. And I just keep on saying, well, what do we know about the impact of it? We don't know any of that. We don't know any of the long-term consequences either. What we do know is that COVID-19 is around, and now we've got a vaccine. And I do have a separate slide on the vaccine, but I might as well address it here. That the vaccine is effective, that we don't have any information to suggest that it's harmful for any. Yes, there are some rare exclusions and there are some rare reactions of an immunological nature that happen, but overall it's safer than COVID-19. We know that breastfeeding, the advice on breastfeeding is unclear. That you can't pass COVID-19 through your breast milk, but that you're still in close contact with your baby. So, you know, it's a respiratory illness, so droplets and all the rest of it, airborne stuff, that's still going to happen. So maybe precaution, washing, whatever it is, there's no clear consensus about whether breastfeeding should or shouldn't happen, and a woman will be supported either way, whether she chooses to breastfeed or not. But there's certainly no guideline to say that you need to separate. And we've actually, through PIMS, have seen the fallout when mum and baby are separated in the early postpartum period, because of course mum and baby are bonding, the attachment is being initiated. And sometimes mums come back and say, they came back a different baby. Well, of course, they're 2 weeks older. They're a lot fussier now. So just keeping these sorts of things in mind. And I'm just really conscious of the time. So I'm just going to go on to, okay, the last few slides are basically some resources. So this particular slide is a resource slide on breastfeeding and network resources. And there'll be further resource slides that I'll flick through that, again, you know, feel welcome to take photos of. I'm going to mute myself now and throw back at the panel if there are questions. I haven't been monitoring the chat, but if there are questions or comments that you need to address.
Thank you so much, Lara. You've done amazing there. And I'm still having internet connections here. That's why I turned my video off, trying to hopefully reduce that. But I'm just going to hand over to Dr. James firstly, and then we'll see if Tanus has got anything to add, and Dr. Uncle. Thanks.
Yes, thank you, Katrina, and thank you, Dr. Havari, once again for wonderful and quite immersive presentation. Look, as you've mentioned, and I'm quite passionate about it, the issue about Valproate in pregnancy, and I mean, I would emphasize again that Valproate used in pregnancy, not in pregnancy, but any woman should be very high. In fact, it should be the last resort when nothing else is can be used as an alternative. When you want to use Valproate, or if you as a GP or a clinician see somebody on a Valproate, you should have a responsibility, a clinical responsibility to asking either yourself or anybody who has started, already psychiatrist who's involved, as to why this woman is on Valproate. So any doctor who starts, or any psychiatrist who starts somebody on Valproate, should be asked to clarify as to why Valproate has been started. If you see somebody who's planning for pregnancy, while you are waiting for this woman to see a psychiatrist, you've referred them to a perinatal psychiatrist, add folate to it. Adding 5 milligrams of folic acid, which is a mega dose folic acid, reduces the risk of neural tube defects. Women who was taking Valproate still has the risk. The risks can last up to 3 to 6 months into conception, which means that the woman should be free of Valproate for at least 3 to 6 months before they plan pregnancy. But as you know, unfortunately, almost 50% of the pregnancies are unplanned. So by the time you see a woman who is already on sodium Valproate, as Dr. Havari mentioned, do not reflexly stop it, because it can be more dangerous than actually continuing it. But at the same time, I must say that Valproate, if it's not indispensable, should be safely changed to something else, of course, with an expert advice of a perinatal psychiatrist. The reason is, unlike many other medications, the damage because of Valproate continues throughout the pregnancy. So the fetus might actually escape the first trimester assault on the neural tube, which means that there might not be a structural damage, but the damage to the cognition, neurodevelopmental course can still happen throughout the pregnancy. And so whenever you find a woman, even if the first trimester is over, there should always be a discussion with the woman as well as a referral to a perinatal psychiatrist as soon as possible to see whether it can be stopped. If it cannot be safely changed to something else, you will continue, but with a very clear documentation of why it is being done and a documentation that has been discussed with the woman and her partner, if possible. So that is an extremely important take-home message. Very briefly, I think we didn't speak much about the postpartum psychosis, but again, it's an emergency. So may end up with a postnatal or a postpartum psychosis. Now, postpartum psychosis is actually a clinical emergency and can be quite serious, quite devastating for the mother, for the family, and for the baby. And so it must be treated to send them to the ED rather than trying to control that episode. Because the key, the essence, is to treat it as soon as possible, as quick as possible, with the most aggressive treatment available to prevent any kind of untoward or irreversible damage, both, in fact, to the mother, to the baby, as well as to their relationship. So three things which are important. And as you know, the postpartum psychosis can present as extreme confusion, almost delirious-like state, where a woman looks very disorganized, disheveled, not able to think clearly, not able to sleep normally, not making sense of what they are talking about, looking very paranoid, looking very distracted, not able to look after themselves. Who have postpartum psychosis should be very high. And if there is any iota of suspicion that this woman could have a postpartum psychosis, refer them to the emergency as soon as possible for them to get aggressive birth plans for women who are at higher risk of developing any kind of postpartum mental illnesses. And so to involve teams like ours, that is perinatal mental health, the perinatal infant mental health teams, or any other perinatal psychiatrist can be very useful in terms of postpartum mental illnesses in the women. So, and that of course requires a very close collaboration in a multidisciplinary fashion with obstetricians, with GPs, and with many other stakeholders, depending upon the client. So think about those things when you have a client or a patient who has a history of mental illness and mental health reasons. Thank you.
Thanks, Uncle. Tanuza?
Oh, yeah, hi. Yeah, I was just one of the things that I often see in, obviously in our sort of day-to-day presentation is the disturbed sleep, and often melatonin is not working for our patient. Have I frozen up? No. Good. To
Bye.